Hello, Rada. How are you today?
Hello, Lina. I'm good, and you? Hi, guys.
Great.
How are you doing?
Hello, everyone. Welcome to another episode of Lina
Lina and Rada
and Rada's
show.
show. So, how are you been, Rada?
I'm good, thank you. I'm busy. And you?
Oh, good. Being at home most of the time because of this coronavirus situation. So, at this stage, this is the third week, right, from of the stage 4 lockdown.
Yeah, correct. Oh,
So we
almost
still have
4 weeks.
almost 4 weeks. So
Yeah.
we are just hanging in there, try to overcome this as soon as
To
possible.
survive, to
Yeah.
emotionally survive.
Oh, well, that too.
Yeah, it's becoming a bit long and a bit tough. I mean, with all this restriction, and we have a
Yep.
curfew. We have to show a paper that we are like we are permit worker, and yeah, it feels like
It
I don't
seems
know.
like a dystopian reality, one of those things
Yes,
that you have seen in movies, about
Hollywood
curfews and
movies.
exactly. So I mean, who would have thought that we were living in these times? But here we are, and trying to do it as best as possible. What else can
Yeah,
we do?
nothing. We just have to to cope with it and try to focus our mind with something else.
Yeah, definitely. In the meantime, we are still thinking about our ADC candidates because as former ADC candidates, we know that this is a process that doesn't stop in your mind, even though you are in a lockdown. So that's why we are recording all the shows because we cannot meet face to face. But by now we are getting pretty good at doing this, remotely through Zoom.
Yeah, exactly. So today we are going to do again another episode of about old TG versus new TG. We are going to talk about a new chapter. Not really new, but they added dental and maxiofacial trauma as
Yes,
a whole and only chapter alone. I think it was pretty much the same as the part that is found in OTG in the medical practitioner management chapter. So they
correct.
were talking about the avulsion, the dental trauma emergencies, and all that. So we found that it was kind of the same, nothing really new.
Yes. That I think they just brought these separately from
Mm,
the like the way that it was in the layout of the old TG. Yeah, but basically, the things that they are talking here are pretty much the same. The process to manage avulsion is the same. Even the pharmacological therapy that you give to a patient who has an avulsed tooth is pretty much the same. So I think nothing really stood out for us in this particular chapter because everything continues and remains the same.
yeah, correct. Next, we are going to talk about the medical emergencies in the dental practice. Again,
Yes,
minor changes, but again, important, especially
important.
for your skilled OSCE days. If you have a new skilled OSCE, or even in a scenario, maybe they can add the scenario how to manage medical emergencies. We never know. So you have to be aware how to manage that.
Yes, definitely. So I think we are getting to the end of this series, right, Rada? Because I think this
Yeah,
will be like the last episode
yeah,
that we are going to do regarding old TG versus new TG. So we have come a long way. So
yeah.
for everyone that is watching the episode now, remember this episode is recorded, but we are going to be probably live watching the episode with you guys the day that this is going to be live. And either way, you can submit your questions in the comment boxes. You can drop your comments there, and we will try after the episode is finished, try to answer your questions live. You know, that will be like a good exercise for everyone here. And like Rada said, medical emergencies in dental practice, and not too many changes, which is good because that means that you don't need to memorize too many new things. But the things that are new are, we think they are relevant, and so it's important, you know, for you guys to pay attention to this episode today.
Yeah, correct. So first thing that we noticed in the allergies, so they added about the acrylates allergy. So the rest was very similar to the old TG. So you have to go and read that small paragraph. Then the rest until the hypoglycemia management, everything was the same. So hypoglycemia management, in the table page 244, so the table talks about the all the management, how you're going to talk to the patient, what you're going to do in case of hypoglycemia in diabetes patient. What changed is the glucose dosage, and it's age dependent. First of all, in OTG, it was 20 to 25 grams glucose. No matter, so it was not depending
regardless
on
of the age of the patient.
Exactly.
Yeah, true.
And now they said that in adults it should be 15 grams, and then they divided the age of the children age, so up to 5 years old or less than 25 kilograms, or more than 6 years old and more than 25 kilograms. So you have just to know that.
Yeah, very important, because remember that in Juroski Day, you're going to have some skiloskis, and medical emergencies has been a part of skiloskis in the past. And we have seen cases about hypoglycemia, you know, and the management of that. So you need to be aware, because you need to adjust your speech depending on the scenario that you are going to be given. You need to keep in mind the age of the patient, so you can adjust the amount of grams that you are going to administer to that particular patient there. So definitely, after just that, pretty much is the same, but the dosage of glucose you need to keep in mind depending on the age.
Yeah. Rest was kind of the same. So yeah, nothing new.
Nothing new regarding that.
So then they added the little kind of little paragraph about
methylhemoglobinemia.
Thanks. Methylhemoglobinemia. I should pronounce it in French, is easier. So this part was in the LA chapter in the old TG. So here they explain a bit more in details about the signs, the features of this disease, and how to manage it.
Yeah,
so you
they
have the box 36.
In page 246, they mention this particular presentation. They say here that it's very, very weird and very rare that a patient, you know, presents an allergy to the anesthetic itself. But basically, if you read the management, which is in box 36, you will see that, I mean, if that happens, there's nothing else that you can do besides call for help, you know, and monitor the patient. Because
you can provide oxygen as well.
Yeah, correct. Basically doing everything that is in the basic life support diagram. It is a serious complication, so it is good that it's not very common, because there's nothing much that you can do in there, but they are mentioned it, and you need to be very keen on that, on reading very well the scenario that you are going to be given, because when you read how a methoglobinemia is present, it says about headache, lightheadedness, shortness of breath. You can confuse this easily with an anaphylaxis situation.
Or
Well, this is,
asthma,
or
shortness of
asthma
breath.
attack. Yeah, correct. So the only difference is going to be that the blood is going to appear dark. So, well, unless you are doing a surgical procedure, you are not going to be able to see if the blood is actually turning color. But this is just new. Just keep an eye on it. Try to establish a difference between an asthma attack, anaphylaxis, and this presentation, so you can be more clear about how differentiate those three in case this is something that is going to be on an OSCE scenario for you guys.
So they just mentioned as well that the most distinct features is the discoloration of the skin, like slate gray, and cyanosis.
Yep.
Okay.
Which can coincide with asthma, severe asthma, and can coincide also with a patient that is not having enough oxygen as well.
So here it's again kind of differential diagnosis, so you can't miss your diagnosis. Anyway, with asthma and this condition, it relies also on the fact that you provide oxygen to the patient. So even if you're not sure 100%, it's not kind of the same. Asthma, you have to give puffs of the bronchodilatator and all that, but here at least we have something in common, just in case, but still you can't miss asthma because you have to provide the bronchodilatator medication, like the puffs and all that.
And also you need to be guided by the medical history of the patient, so it's not about just the signs and symptoms, but the information that they are going to give you about the previous medical history of the patient.
Exactly, that's why it's very, very important to be thorough in our a questionnaire with the medical condition, the history, medical history, and all that.
Yep, correct.
Okay, so stroke, Lena.
Stroke, I think stroke, in stroke, there's something that is, basically the description about the signs and how you spot a stroke are the same. The management of stroke, it's pretty much the same steps, but they are asking you here to establish the oxygen saturation of the patient in order for you to decide if you need to give supplemental oxygen. So remember, at the beginning of this chapter, they are giving you all the things that should be in an emergency bag at your practice. And one of those things that are in those bags is let me just get the right name, the pulse oximeter. And that's the little thing that you put in one of the fingers, and it's going to measure the available oxygen that the patient is having. So here, in contrast with the old TG, they only mention give oxygen straight away to the patient. But here they are saying, don't rush into giving supplemental oxygen. Just put the pulse oximeter in the patient's finger and establish what's the saturation. So if the saturation is less than 90% of oxygen, then we are going to give supplemental oxygen to take that saturation at least up until 96% of saturation. So that's basically the difference. But for everyone that has been working in a practice, at least here in Australia, even though if you guys are practice manager, clinical manager, dental assistants, whatever, you will see that all the practices by regulation, they must have an emergency bag. And inside of that emergency bag, as a standard, they always have a pulse oximeter. Super easy to use. And when you get the training that is required by law here in Australia, the person that gives you the training show you how to use the pulse oximeter. I do know that at the Institute of Dental101, when we train people for us, skill OSCE, stuff like that, we have these available, and they also have a chance, you know, to try it and to use it and to put it in the finger. Yeah, so don't be afraid of doing that in case you get an OSCE of a patient that is having a stroke. That is going to be hard to, you know, to recreate for them. But just, you know, in the particular case that you get an OSCE and you think that that's a stroke, you need to look for that pulse oximeter to establish the saturation. So I think that's basically the minor changes that you are seeing there.
So then we move to unilateral blindness. So page 252. So they were talking about that in OTG, but here they separate the injection of LA containing vasoconstrictor, and they added the injection of dermal fillers because nowadays it becomes very common for dentists to inject these kind of products. So they are giving you the management. So if it's an LA with a vasoconstrictor, then you have to stop the treatment, call 000. Like the patient must be taken to the emergency department. And again, if the patient is unconscious, you have to do your basic life support procedure. So remove danger and blah, blah, blah.
Yep.
And the injection of dermal fillers, basically, again, you stop treatment, you call 000. You note the time of the when started this blindness, the onset, and the time that the emergency arrives, the assistance arrives. Then you have to assess the deficit, the presence of any symptom of stroke, because maybe it could be a differential diagnosis that you have to do, like facial weakness, unilateral weakness, difficulty with speech. So we want to be sure that it's not a stroke, even though we are not medical practitioner, but at least it can guide them when they arrive. And you have to assess the presence of any symptoms or signs on the skin. If you have pain or bleaching, blanching, of the skin, which could be something else. So if you have injected hyaluronic acid, then you inject the hyaluronidase, which is the enzyme that reverses the reaction and will kind of eat or remove all the hyaluronic acid.
So yes, I think nowadays they are trying to keep up with all the trends that we are seeing as dentists. And usually you see a lot of dentists doing dermal fillers, Botox, stuff like that. So I think that if you are doing that, if you fall into that group, you need to be prepared to deal with emergencies related to that. So that's new, keep it in mind. I think this is going to be also quite useful for part 1. So it's very hard to recreate an OSCE about a dermal filler, but probably this theory is going to be important for any candidate that is going to sit for part 1 and needs to.
It could be one question.
It could be one question related to that. So that's one new thing in there. Okay, and then we go to respiratory emergencies. So hyperventilation syndrome, it's pretty much the same. But then we have acute asthma, and that one has changes, right, Rada?
Yeah, exactly. So table 25, so you have this table for the initial assessment. They give more details about the clinical signs, for you to be able to assess and identify the severity of the asthma attack. For instance, now they talk more about the oxygen saturation, if it's less than 90% in the life-threatening case, exhaustion. In the severe, you have the subcostal recession. Again, the oxygen saturation here between 90 and 94. They were talking about the accessory muscles, but here they are a bit explaining a bit more, like few words, but it is more accurate.
Yes.
Then they give us the management box 46, the following page, and here they so for the mild and moderate asthma attack is the same, but for the severe or life-threatening, they ask you to give oxygen, airway support, but here is the change is that they change the number of puff depending on the age, patient age. So if the patient is an adult or a child 6 or more year old, then you have to give 12 puffs. Whereas a child younger than 6, then you have to give double less, like 6 puffs. These are the changes that we noticed in the differences between the two versions.
Yeah, and I think I just want to reiterate here the oxygen saturation. So Rada mentioned that in that table 25, they are mentioning again that. So again, the pulse oximeter is going to be very important. You need to know how to use it, how to put it in the patient's finger, how to read the saturation to establish the need of oxygen. And of course, like Rada said, just keep in mind that for a severe asthma attack, we have now that the puffs are going to be age dependent. So that's
age
important.
dependent. Yeah, correct. Yeah, and the necessity of checking the oxygen saturation looks very important. So really try to not forget that.
Yeah, and that's one thing that is super easy to do.
Yeah.
So don't stress. It's not that putting that thing in the patient's finger is going to be, you know, like a massive hustle. No, but remember that when we are in an OSCE, we want to appear like we know what we're doing. So if you haven't had any contact with a pulse oximeter before, everything is going to look quite weird. So it's good for you to try to be trained on that just before, you know, just to appear that you know what you're doing.
Yeah, also we can always watch YouTube videos, but because we haven't practiced ourselves, I think day of exam with the stress and all that makes things a bit weird or messy, or we are not sure and we can lose confidence quite rapidly and we can panic, and then you know the story. But I think it's really important to do it at least once or twice ourselves. So if day of exam it happened, I mean, if we have a scenario like that, not mentioning, but requiring the use of a pulse oximeter, then you'll be very confident. And also remember, in emergencies, the dentist must be confident, so this attitude will reassure the patient that is in a distressful situation. So we have also to be professional, reassuring the patient, be confident with our movement and our attitude.
True, agree, completely agree. Remember that when we are talking about OSCEs, it's a game about you know, having a poker face, you know, and try to endure the process with apparent no stress, which is quite tricky sometimes. Okay, and then we move to inhale or swallow objects.
Yeah.
And in that particular one, the table 26 in page 257, that one gives you the signs of partial airway obstruction and the signs of complete airway obstruction, which when you read it is basically the same that the OTG, but with different words. And I think this one has simplified that table. So it should be quite easy for you to establish a difference between a partial and a complete airway obstruction. So that one, pretty much the same, but different words. Just take a look so you can see what's going on there. And then when you move to box 48 in page 259, the management or inhale or swallowed object. So in the old TG, the management for airway obstruction was based on partial or complete airway obstruction. But here, the management is based on if the patient is conscious or if the patient is not conscious. Because you can have consciousness whether if the patient has a partial or a complete airway obstruction. So here, they are focusing on the consciousness of the patient to establish the management that you need to do. Again, in this one here, it is very important for you to read how to do the management, because when the patient is conscious, that's when we are going to give the 5 blows or to try the chest thrust. But if the patient is unconscious, that's not something that we do. So that one has quite a bit of changes. Just, you know, try to read it carefully to establish what to do.
Yeah, and also in that little paragraph in the event that an object appears to have fallen down to the oropharynx region, before they asked us to have a chest X-ray to confirm or to identify maybe the location, but now they don't mention it at all.
Yeah, I think they are establishing here that if the patient is conscious, probably the X-ray is not prioritary here. So that's why they are not saying it. But we were very used to, you know, like as soon as we knew patients felt something, chest X-ray is the first thing that you need to do. But here they are not recommending that one. So there's quite a bit of changes in the management of airway obstruction there due to inhale or swallowed objects. So make sure you guys read that very thoroughly. So
I was going to say, like the chest X-ray, maybe if we call the assistants, then they are going to do this kind of management. We don't need, because if we have a partial obstruction and we can solve it, then we don't need to do the chest X-ray. But if the patient is still having this obstruction, and again, of course, we're going to call the emergency. So the assistants will do this kind of checking, because we have this unconscious patient. We cannot find or retrieve the object and so on.
Yeah. And I think there's a lot of point of views to try to establish the need or not of a chest X-ray. What you have here in TG is the clinical management of that particular accident or emergency. Obviously, people can say that from the medical legal point of view, it will be better that you have a chest X-ray. I mean, whatever. Remember that for the purposes of OSCEs and the practical examination itself, we just need to adhere to what's written on TG. So that's what you need to do, you know, for the purposes of the exam of a particular OSCE. Obviously, outside in the real world, probably someone will tell you, doesn't matter, just go and send the patient for a chest X-ray because it's better for you to be covered on all bases. Fair enough, but for the purpose of this exam, just follow what's written there and it's going to be good enough for you.
My question is, maybe, I think it's not totally incorrect if you just prescribe or send the patient to a chest X-ray. It's not something that will make you fail your OSCE, because you still show that you're concerned, you are safe, you want to confirm things. So if you don't mention it, you don't fail, because it's not in the new TG. But I think, if that's my personal opinion, but if you mention it, it's not incorrect either. So
true. I think the purpose of an OSCE, no, I'm completely agreeing with you, Rada. I think the purposes of the OSCE is obviously manage the emergency at the moment. Once that is completely managed, obviously a few more things you can say and it's not going to fail you. Completely agree. I mean, what will fail you is not following those steps that you have there, but everything that could be additional to that can help you have a peace of mind, you know, like the chest X-ray is not something that will fail you here, definitely. So what you need to keep in mind is, for the purpose of managing the emergency at the spot, what is written on TG is what you need to do. And, you know, everything that you can add that can help manage the situation is not going to be bad. So I'm agreeing with you on that.
It's a bonus.
Yeah, it's a bonus, definitely. Okie doke.
Yes,
So,
finished.
new TG finish versus old TG. So we have a lot of recorded episodes about this. So I think everyone is going to be seeing all those recorded episodes. Um, it's a work, doing this. Again, guys, don't take our word for everything that we have said here. Everything sometimes is subject to interpretation. We have tried to read this in a comprehensive manner just to give you some advice and a quick overview, but definitely you guys need to go back to the new TG, read it very thoroughly, understand it very thoroughly, try to connect things in order to improve your performance in the exam. But I think we have covered pretty much all the bases, and that's pretty much it.
Yeah, it's a great achievement, I want to say.
It is, because we have been doing this for,
Weeks.
quite a bit. Yes, for weeks. So hopefully what we have done with the old TG versus new TG is something that can help you guys at least, speed up things for you in order to understand what is written there. And yeah, now we need to think about new subjects for the upcoming episodes, because we have been doing this old TG new TG thing for quite a bit of time now. Again, if you guys have any questions regarding this particular episode, just leave it in the comment box. Yes, and we will try to answer these questions when the time comes.
And if you like the video, if you like the video, press a thumbs up or a heart to show us your love.
In this time. Heart. Yes. If you also have any kind of ideas or suggestions on what topics do you want us to discuss, just send them through as well. You can send it directly to the center, Dental101. Or you can say it in the comment box as well. We are open to everything. Like we said at the beginning, this is made just to try to have fun regarding everything that is surrounding the practical examination, because it is stressful enough. So this space is, free,
it's a relaxed
free of stress.
Conversation, just a chit chat between you and us, just helping, but in a relaxed manner.
Yes, definitely. So if and when you are seeing this episode, the coronavirus is still a thing in everyone's life, just hang in there. Be strong. We are able to do this. Remember, we are all in this together. So just hang in there.
6 months lockdown. Yeah.
Oh my God. Yes. Well, get in there. I'm sure we are going to be able to overcome all of this.
Yeah. One day.
Yes. Thank you so much.
Thanks, guys.
Thank you so much, guys, for watching.
Bye-bye.
Bye.